Welcome everybody, my name is Ádám and I'm a third year resident student, doctor, and my whole PhD topic is endometriosis-related pain relief. I have a personal vision, of course, and it sounds like endometriosis-related pain should be a concept of the past with one pill a day. And my mission is to find the most effective pain relief therapy for endometriosis. Here you can see my two ongoing projects, and yes, I changed the order of my project based on the competition level of my projects. So I start with my first one. It's comparison of robot-assisted versus conventional laparoscopy for treatment of endometriosis. It's a systematic review and meta-analysis. Why this topic is so important? Endometriosis is a common disease and it carries high individual and society costs, and that's why there's a huge pressure and a growing need to treat with the most appropriate and the highest quality care. We have plenty of therapeutic options, but I would like to focus only the surgical interventions. At this time, we have two surgical options, the method. The first one is a conventional laparoscopy, which is the gold standard at this time. And in recent years, robot-assisted laparoscopy are gaining ground. Of course, there's a third option, the laparotomy, but at this time it's only a rescue option. Here you can see a list what robot-assisted laparoscopy offers to us: reduced pain, less blood loss, fast recovery, etc., etc. But we know that in other surgical field we can see these advantages. But my question is, do these advantages come out in practice for endometriosis surgery? That's why we would compare REL and CL for endometriosis surgery regarding the perioperative outcomes. Our question is REL safer and more effective than CL in the field of endometriosis surgery? The patients, our population is patients who underwent surgery for endometriosis. Our intervention is REL, our control is the CL, and our outcome is different perioperative outcomes. And based on the previous slide, our hypothesis sounds like REL is superior to the CL in the field of endometriosis surgery. And at the end of the whole process, we will turn this knowledge next to the patients and improve the surgical treatment of endometriosis. We perform a systematic search. Here you can see my search numbers and my search key. And at the end of the whole process, we got 13 eligible articles. Here you can see the previously mentioned outcomes. And I would like to highlight you that except the operating room time and operative time, surprisingly, we can't see significant difference, and we can't see the advantages of the REL. So that's why I bring to you the operating time, my operating time figure. And what we can see here, we compare the REL and the CL regarding the operative time. The measure of unit was minutes, and what we can see is about 30 minutes difference. So the REL lasts 30 minutes longer than the CL, but we need to know the background of it, which is how we measure this. From skin incision to one closer. So this time difference contains the docking time, the REL docking time. So it's partly because of the docking time. And we can see a high heterogeneity. It's because some authors only did certain interventions, for example, only cystectomy. This is my baseline characteristics table, and I would like to highlight you. We got only one RCT, And another one is in 3 cases, we don't know any information about the surgeons who perform these interventions, and a little bit problematic regarding the biases. Our strength is we followed our protocol, the long study period, and the large number of cases. And as I mentioned in the last slide, we have most of the articles are retrospective studies. We have some authors only did just some certain interventions, and we got moderate and high risk domains under the risk of bias. Okay, and our conclusion is for endometriosis surgeries, REL does not have any statistically demonstrable advantages over CL in terms of perioperative outcomes. The implication for practice is a little bit different at this time, and it's a complex, we can give a complex answer, and we need to deal with the factors that not yet being qualified. And the implication for research is we need to carry further randomized studies, and we need to investigate the medioeconomic impact of the 2 approaches. We finished the manuscript. At this time we polish our manuscript and correct the mistakes. As you can see, I have only one target journal because there's only plan A, and if it's failed, that could be plan B, but at this time, just one journal. And that was my first project. And let's turn to my second project, investigating the most effective medical treatments for endometriosis-related pain. It's a network meta-analysis. We know that almost every 10th woman suffering from endometriosis, and the symptoms can be very diverse. For example, dysmenorrhea, pelvic pain, dyspareunia. Of course, we have plenty of therapeutic options, but in this study, I only focus medical therapies. We can divide it to 2 groups based on hormonal treatments and non-hormonal treatments, and we should divide it to 2 more groups, the hormonal one, based on the length of the use. We have short-term and long-term therapeutic options. Short-term means we can use it only for 6 months. Here you can see the long-term therapeutic options. The green bubble represents the importance of the drug type. And in another slide, we can see the short-term therapeutic options. We have 2 types of drug in this group. Our question, which is the most effective therapeutic option for endometriosis-related pain? Patients, women of fertile ages with endometriosis, we compare the different medical therapies, and our outcome is the endometriosis-associated pelvic pain. We have 2 hypotheses. The first one, oral combined contraceptives are superior to the other long-term therapies for endometriosis-related pain, and the second one is the same with the short-term therapies. At the end of the whole process, we will turn this knowledge back to the patient bedside. We perform the systematic search, and my search is a little bit busy, so I made boxes. Here you can see the 4 big part of it. At the end of the whole process, we got 47 eligible articles, and at this time, we finished the grading, and we analyze our data. So that was for today, my 2 ongoing projects, and I will thank you for your attention with a Latin phrase, quid pro quo, something for something. Thank you.
So first of all, congratulations. And my question would be that, do you have any data about how endometriosis affects the fertility of women? And my other question is that, what are the main hormonal problems with endometriosis?
Yeah, thank you for your question. My first answer is we did not investigate the endometriosis effects on fertility, but almost 60% of infertility caused by endometriosis, but we not deal with this part of the disease. And can you repeat your second question? Sorry.
So, what are the main hormonal problems with human women with endometriosis? So.
Yeah, not the hormonal part is the most important. Maybe the physical effects in the abdomen. It's like we put glue in the pelvic, and it's put everything together, everything together, and it's also affect on tubes, and it's the biggest problem with it, not the hormonal ones.
Okay, thank you.
For your presentation, I have two questions. For your first project, what is the current clinical practice? Do you use robot surgery for this indication now in Hungary? What are the results?
Yeah, it's a little bit difficult, as I mentioned. So we need to think a lot of factors that not yet been qualified. For example, the comfortable for the surgeons, or if you made a robot-assisted laparoscopy, the surgeon can sit and not stand in a very, very rigorous position, and a lot of other advantages which we don't have any numerical data. So at this time, we can choose based on our own experience, the surgeon experience, and think about the financial part. It's also very important. So the hospital financial background is very important when you choose which approach do you use. For longer interventions, it's a better technique, the robot-assisted, because in a short, based on the docking time, it's consuming a lot of time. We can say we waste our time with docking, but when we do longer process, it will be not a huge effect.
And about your second project, you said one pill a day. Do you think or maybe combinations could be better? And are you looking for the combinational therapy regarding the medical therapy of endometriosis?
Yes, thank you. At this time, I think it's just a vision. Maybe if some huge new research will appears in the future, it could be a good option. But as I mentioned, not the hormonal part is the most important. So we need to solve this problem. We can only solve this problem maybe with surgery, and helps with a drug, with a pill.
Just one question from me, which is regarding your topic. So, although there's so many advantages of the robotic-assisted laparoscopy, there is very few disadvantages. How would you explain what is the reason of it? Because one disadvantage is the lack of tactile feeling.
Yeah, it's one of that. The tactile feedback is missing. But I think my personal suggestion is the surgeons spend their life, the most of their life with laparoscopy, and only in the last decade use robot-assisted approaches. So maybe in the future they will better and better, and we will get better results, and we will see this advantage in the future. So we need to further...
I agree with you, because this is endometriosis is a very difficult kind of surgery. So and it's done mostly by the very experienced ones. So therefore they are able to achieve as good results as with the robot. But if it's going to be done by less experienced ones, probably robot will be also.
Yeah. They need time.
Thank you very much.